over. Again, this is the cirrhosis. We're going to begin on page 1159. In talking about cirrhosis, we know that it is inflammation of the bladder. And on page 1159, it tells you that it's an irreversible scarring of the liver. It's inflammation of the liver, and it is irreversible scarring. So some of the causes for that inflammation could be there's been exposure to any toxins, or maybe it's been a disease that person has had trouble with that is causing some extensive degeneration and destruction of those hepatic cells. But as that cirrhosis develops, the tissues are going to become nodular. It's going to be fibrous type tissues within the liver. The nodules can begin to block the bile ducts, and that normal blood flow through that liver is going to be impaired. So there's going to be impairment in blood and lymph flow because of compression caused by that fibrous nodule type tissues. In the early disease, the liver is usually going to be enlarged, and it'll feel firm when you palpate in that upper right quadrant of the abdomen. But as that disease continues, the liver will then begin to shrink in size, and it will become still harder and firmer, but it's going to decrease in size, and that's when you're going to start seeing more liver dysfunction. The impaired liver function is going to cause an elevation in the serum liver enzymes. So all of those liver enzyme tests that we talked about yesterday will still be elevated, and we're going to talk more about the liver enzyme test today. There are different types of cirrhosis, and we're going to talk about some of the common types. The post-necrotic cirrhosis is caused by a viral hepatitis, especially if you develop hepatitis C. The Lennox cirrhosis comes from abusing alcohol. It's caused by chronic alcoholism. And then biliary cirrhosis can be caused by chronic biliary destruction or some type of autoimmune disorder. Now, there are complications of cirrhosis, and you see those listed on page 1156. And the main common complications is going to be that portal hypertension, it's going to be ascites and esophageal varices, biliary obstruction, and then hepatic encephalopathy. I thought we had a video. There it is. Complications of cirrhosis. So let's talk about it first, and then we're going to watch a short video clip that's going to illustrate this for you. When you have portal hypertension, this is going to cause a persistent increase in pressure within the portal vein leading from the liver, and this is going to cause increased resistance or obstruction, blockage of blood flow through that portal vein and the branches. And the blood meets resistance to flow, and this causes collateral vessels, an alternative way for blood flow to get around that blockage will develop. Now, while this is occurring, all of this backup and pressure caused from the obstruction is going to create free fluid within the peritoneal cavity. And the result is going to be there's going to be a fluid shift into the vascular system, into the abdomen, and you're going to see a third spacing of fluid. And that's what's responsible for the large abdomen, the large truncal edema that you'll see on the body. Again, because of that resistance of blood flow and the obstruction, all of that should be draining. The bile flow, the blood flow, the lymph flow should be draining on into the body, but instead it's backing up. So if it's backing up, what kind of collateral circulation is developing in the esophagus, in the stomach, in the rectum? varices. You know, we tend to talk about esophageal varices that's in the esophagus that will break and bleed. They're very friable type vessels. They're not the best vessels at all, so they can easily bleed. Just like the thrombose hemorrhoids are, that you may see external hemorrhoids, rectal hemorrhoids. Well, those are developing inside of the esophagus. It could be in the abdomen as well, the stomach, and of course is in the rectum. And so that's pressure, and that's puts the patient at a big risk for having some bleeding and hemorrhage to occur, because those vessels are fragile. They're thin wall. They can become distended and tortuous from the increased pressure, and there's a potential for that varice or that vessel to burst and start bleeding. Another problem or complication from having cirrhosis is that you will have decreased prothrombin time, and the clotting factors are decreased. Remember, the liver is responsible for that function. So if the liver has dysfunction, it's not going to be able to keep that blood clotted well. And so severe blood loss can occur from either vomiting. You'll see vomitus of blood. You may see tarry or bloody stools, and you may see a change in that patient's level of consciousness. Now, one thing to remember with the esophageal varices is that they can rupture spontaneously and start bleeding. So any normal activity when you have cirrhosis and esophageal varices is that any normal activity like straining to have a bowel movement, any heavy lifting, or any vigorous type of physical exercise, any chest trauma or hard food in the esophagus can cause bleeding. The next complication we're going to talk about is the biliary obstruction, and this is where the production of bile in the liver is decreased, again because of dysfunction, and this prevents the absorption of the fat-soluble vitamins. The fat-soluble vitamins are DEEK. Everybody say DEEK. D, vitamin D, E, A, and K are the water-soluble vitamins, and so this is going to prevent absorption. And you all know, again, if you don't have vitamin K, you're going to have some clotting factors that are not being produced in sufficient amounts that could lead that patient to be susceptible to bleeding and early bruising. The last complication we're going to talk about before we watch the video is going to be hepatic encephalopathy, and this is a cognitive syndrome that will affect those patients that have liver failure or cirrhosis. And what happens is that these people have a buildup of ammonia in their brain. The liver is not getting rid of the ammonia because what's happening to the liver? That hepatic duct, the hepatic vein is stopped up, it's obstructed. So instead, they are going to have a buildup of ammonia, which is going to lead them to develop some sleep disturbances. They have some mood disturbances, some mental status changes. You'll see that early, but later they will begin to have neurological symptoms like altered level of consciousness. They're going to have impaired thinking ability and impaired neuromuscular type problems. Okay, now let's watch the video.
When you're ready to begin treatment for chronic lymphocytic leukemia, Calquence helps you do the fighting, and you can do the exploring.
Portal hypertension refers to high blood pressures in the hepatic portal vein, the large vein that carries blood from the digestive tract, spleen, and pancreas to the liver. Within the liver, blood runs through tiny channels where it exchanges contents with the liver cells. This is where nutrients are processed. Toxins and pathogens are removed from the blood before it exits the liver via the hepatic veins to enter the general circulation. Portal hypertension usually results from an obstruction or an increased resistance to blood flow, which may occur before, within, or after the liver. Most commonly, it happens within the liver due to liver damage in diseases such as cirrhosis and schistosomiasis. Cirrhosis is by far the most common cause in developed countries, while schistosomiasis, an infection by parasitic flatworms, is more prevalent in children from developing countries. Cirrhosis is the widespread scarring of liver tissues caused by long-term alcohol abuse, chronic viral hepatitis, or fatty liver. Clinical presentation of portal hypertension may include abdominal distension, known as ascites, a result of fluid leaking into the abdominal cavity under high blood pressures. Enlarged spleen due to congestion of the splenic veins. Formation of so-called collateral vessels as alternative routes for blood to bypass the liver. These new blood vessels connect some digestive organs directly to the general circulation. By doing so, they reduce blood flow through the portal vein and relieve portal pressures, but they may also cause serious complications. As blood pressures increase, these small vessels can become engorged and form varices, which may rupture and bleed. Variceal bleeding can be massive and life-threatening. Because collateral vessels direct blood away from the liver, toxins that are normally removed by the liver can now reach the general circulation and pass into the brain, causing symptoms such as confusion, drowsiness, tremor, or even coma, in a condition known as hepatic encephalopathy. Treatments aim to prevent and manage digestive tract bleeding and include ongoing monitoring with endoscopy and a variety of drugs. If these fail, surgery to reroute blood flow may be performed. Liver transplantation may be needed in case of severe liver damage.
Okay. So what questions do you have about the video in discussing a lot of the main complications of having cirrhosis? All right. So let's move along to page 1158. And the video alluded to what are some of the most common causes for cirrhosis in the United States. Okay. The hepatitis C especially is the leading cause, but chronic alcoholism, sometimes some of the chronic viral hepatitis, and even bile duct disease, as we talked about yesterday. Something that's rapidly developing in the United States because of obesity is another cause for cirrhosis, and that's that non-alcoholic fatty liver disease. All right. Let's get to where we're going to be assessing your patient. What type history will you obtain from your patient that you suspect that has a liver dysfunction going on? Yeah, asking them about alcohol use or any drug use. Any family history of these things. Needle stick injury, if they've had any history with the hepatitis, their sexual history, because they're finding that those that have, I don't want to say risky sexual behaviors, but they're finding that some of the homosexual males are prone to transmit hepatitis, mostly, are the hepatitises. So what type of physical symptoms will the patient with cirrhosis report? What symptoms will they report? Okay, so they're going to be fatigued. They may have a significant change in their weight. They're going to have some GI symptoms, mainly decreased appetite and vomiting. And they're going to have pain in the abdomen. Where, especially in the abdomen, will they feel the tenderness? Okay, the right upper quadrant. You may feel that liver if it has already become fibrous, or you may palpate and see that the patient has tenderness. Okay, oftentimes patients that are having trouble with their liver, they come into the clinic just for routine lab work, and oftentimes that's when the liver enzymes are noted to be elevated. A lot of the times when patients begin to have symptoms of liver dysfunction, that's sadly when the damage has been done. So what are some of the late signs of cirrhosis? Okay. The ascites, they're going to have some peripheral edema of their extremities and their sacral. Remember, they're going to have some malabsorption from the water-soluble vitamins, DEEK. Dry skin, rashes, and itchiness because of the bilirubin is not being excreted from the body, so it's staying up under the skin. And that bilirubin under the skin is what's causing that dryness to occur and also the itching. Okay, what are going to be some significant findings when you're doing an abdominal assessment on someone with cirrhosis? You're going to see tenderness, distension. You may see some dilated collateral vessels on the abdomen from distended abdominal veins. You may see some ascites, and they may have some respiratory discomforts, because if your abdomen is very large and huge, is it going to be hard to move that diaphragm up and down when you're breathing? So they may have some orthopnea where they can't really sleep laying down. They may have dyspnea at rest, dyspnea on exertion, and they're going to have increased abdominal distension. Okay, so when you're performing an assessment of the abdomen, you have to keep in mind that they will have some hepatomegaly where the liver will be enlarged, and they may have some splenomegaly too. These are some common findings for the patient. What are some other physical assessments that we will observe for with a patient that has liver dysfunction, may be diagnosed with cirrhosis? Okay, so we're going to have to monitor them for bleeding. We're going to be looking for those type symptoms. Because remember how we talked about the portal hypertension, the risk for esophageal varices, and really bleeding throughout the whole GI tract could occur. Right. Acetaminophen and Tylenol, that are excreted through the liver. All of those. And it's interesting that you mentioned that, is because every liver function that the liver usually carries out, when there's dysfunction and you have elevated liver enzyme, the liver is not functioning at all. So all of that normal function that was occurring, like keeping your platelet count within normal range and things like that, is not working properly anymore. So you're going to certainly have to observe for bleeding in your patient. At the bottom of your page, it talks about Phlector hepaticus. What is that? A fruity, musky type odor of the breath. And what is the asteriskit? That's that rapid tremor that they may have, or a hand flapping. That usually occurs with the hepatic encephalopathy. All right? What would you expect for the laboratory results to reveal in a patient with cirrhosis? Okay? And so all of those that they're calling, like the AST, the ALT, the LDH, they're found on page 1161, table 53.3. All of those are enzymes, liver enzymes, the GTT, all of those will be elevated. Okay? When you look at the bilirubin labs that works with the liver, all of those will be elevated. The majority of them will be elevated. When you look at the serum protein level, there's one that's going to be decreased. Actually, there's two, but the albumin levels. Doesn't the liver function with protein and albumin? If it's not functioning properly, you're not going to have that albumin and a healthy amount of protein in your body. And since you have decreased serum albumin, what do you know albumin, low albumin levels mean for a patient? Are they going to have increased swelling or decreased swelling? Increased swelling on the body. Okay? And then the other tests on page 1161, you'll see that that ammonia level is going to be elevated. So you will see elevated liver enzymes, elevated liver studies, all of those will be elevated, and the serum ammonia level will be elevated, but the serum albumin level will usually be decreased. How do they know that there's something going on with the liver? Say that your provider has looked at the liver enzyme tests and they are elevated. What's the next step for the provider? Or what would the nurse anticipate the provider to do? X-rays. You need to see if that liver or the spleen is enlarged, and they can do that with a plain X-ray called a KUB, kidney, urethra, and bladder test. An MRI or CT scan can actually reveal the enlargement or the mass or any lesions that are there. Also, they could do an ultrasound to see that the liver maybe has ascites in it, or that there's hepatomegaly or splenomegaly. So those are the tests that you would anticipate being ordered for a patient with cirrhosis. Now we're getting to the problems that the patient with cirrhosis or any liver dysfunction is going to develop. They will have fluid volume overload because of the third spacing of the abdominal and peripheral fluid. Also, they're going to have fluid volume overload because the albumin level is decreased. They're going to have a potential for hemorrhage due to portal hypertension causing the obstruction, and collateral vessels are forming that are friable and easy to bleed. So they're going to have a potential for hemorrhage. The other reason they have a potential for hemorrhage too is because the clotting factors are not being produced like they should. The patient with cirrhosis will have problems with acute confusion and other cognitive changes. Again, this is due to the ammonia level and any alcohol withdrawal if they've been abusing alcohol before admission to the hospital. And again, this acute confusion is due to the hepatic encephalopathy. And then, of course, the patient will have complaints of just the dry skin, the itchiness of it, and this is due to the increased serum bilirubin underneath the skin and the jaundice. So how are we going to manage these patients? How does the nurse help manage fluid volume in the patient with cirrhosis? What do we start with? The diet. What type diet will a person with cirrhosis need to eat? Low sodium diet. At least 1 to 2 grams sodium restriction should be tried. You're going to teach that patient to read labels on their food and their beverages, and any table salt, no kind of extra salt should be added to their diet. What if they're in the late stage of cirrhosis and they have malnutrition and multiple dietary deficiencies? What would you anticipate being ordered? The IV vitamin supplements, and if they have abused alcohol, you're going to treat them the same as if they're going through withdrawals from alcohol, and that they are malnourished like a alcoholic may appear. So you would give IV vitamin supplements, thiamine, folate, multivitamin preparations, and things of that such. What medicine would help to relieve peripheral edema and ascites edema? Diuretics. And once you start giving the diuretics, you're going to have to evaluate whether those diuretics are working. So how would you evaluate? Weighing them daily, measuring intake and output, the abdominal girth, okay? And you're going to be looking at the lab, because we know that when you give diuretics, what else are they losing besides fluid? Electrolytes. They're losing electrolytes, and they can become dehydrated. And what's the main electrolyte they may be losing? The potassium, okay, especially if they're given furosemide, a loop diuretic. Another diuretic that is a potassium-sparing one is spironolactone. It will be given to help with the treatment of ascites. And because these drugs work differently, you're really going to have to monitor for electrolyte imbalance. There is a spontaneous bacteria peritonitis that could occur with the ascites. So when you are assessing the abdomen, be sure that you're also listening for bowel sounds and assessing the abdominal wall for any rigidity. Another thing that will get rid of the ascites is paracentesis. What's a paracentesis? It's a treatment that they're going to use, a procedure. It can be performed at the bedside. It can be done at a radiology type clinic department or ambulatory care setting, but they will use a catheter to drain into the abdomen and remove the ascites from the peritoneal cavity. And this procedure is done using ultrasound to make sure that they do it correctly and safely. Someone read to us best practice for patient safety and quality care for the patient having a paracentesis. What does your textbook recommend? Okay. One of the most important things you need to do with a paracentesis is obtain those vital signs before, and you certainly must get them after the procedure. Because when a paracentesis is done, it could be volumes, liters, volumes of liters that are removed from the abdomen. And the patient is used to having all that on their body. But once it's removed, it's just like hemorrhaging out or losing a lot of fluid all at once. So the patient could go into shock. So you want to make sure you know what that baseline blood pressure is, and then you need to make sure that you are evaluating the blood pressure, the vital signs, all of them, after the paracentesis. Some other things that you would do is measure the drainage and record it. Document the characteristics of that peritoneal fluid that's been drained off. You're going to label and send the fluid for laboratory analysis, especially if they think that the person has peritonitis. They'll be able to send a specimen for culture. And then after the catheter is removed, you're going to apply a dressing to the site and assess it for leakage. And then that patient maintains bed rest, whatever protocol there is. Okay? So that's how we're going to help manage fluid. But what about the patient that still needs some respiratory support while they still have the ascites on them? What does the nurse make sure to monitor? Lung sounds, that's right, because they're going to be complaining of shortness of breath. And once that paracentesis has been performed and you ask them if they're short of breath, what do you think they're going to say after the procedure, after they've had 3 liters of fluid removed from their abdomen? They feel a lot better. They're not as short-winded as they were. So we need to be sure that we're listening to bowel sounds, not bowel sounds, but breath sounds. And we need to make sure that we're monitoring their electrolytes, looking at their urine function and their electrolytes. What questions do you have about taking care of the fluid volume problems? It's just general basic care that you've already learned from Nursing 1. You remember some of that content? Okay. Nursing 2, is that where you had your fluid and electrolytes? And you learned about fluid volume overload, fluid volume deficit. It's some of the same things. Now, how does the nurse manage hemorrhage? How will the nurse know that this patient is bleeding? If they have esophageal varices bleed, how will you know? Yeah, they're going to be vomiting up blood or spitting up blood, and you may see upper GI bleeding. And if it's in the rectum, you may also see the lower GI bleeding. But before the patient is been at the hospital for a long period of time, admitted with cirrhosis, they're going to already have been screened for any esophageal varices. So they will do those early because they are anticipating a possible GI bleed. What medication will they put the patient on to prevent the GI bleeding from the esophageal varices? Propranolol, that's right. Old drug called Inderal, same thing, propranolol. Some of you may be taking it now for test anxiety. Don't you just love those drugs that are wonder drugs for multiple things? But propranolol will be given, and this decreases the heart rate, which in turn help to decrease that venous pressure, and the chances for bleeding is lessened. Now, what if bleeding does occur? What should the nurse anticipate having an order for? Which med? Not for bleeding. Vasoactive drugs, okay? And so one of the ones that your book talks a good deal about is the octreotide. This is going to reduce blood flow through vasoconstriction and decrease that portal pressure. It's also going to suppress secretion of a lot of enzymes, which will decrease blood flow to help with pressure reduction within the varices. So this vasopressin, octreotide, is used less common because it's a very potent drug. Some other things that will be done for esophageal varices bleeding is that they can manage it with an endoscopy variceal litigation, like they'll band it and put a band around the varices to decrease the blood supply. They have other procedures, endoscopy, sclerotherapy, where they will inject a sclerotherapy med in the varices that's bleeding to stop the bleeding. Another one that you probably heard about is the balloon tamponade, where they can put down, it's similar to an NG tube that's placed through the nose into the stomach, and then they attach a balloon to inflate it. It inflates the NG tube, and when it's inflated, it puts pressure on the esophageal wall and will put pressure on those bleeding esophageal varices. And then there is a procedure called the TIPS that could be done in the radiology department, where they can stop esophageal bleeding. But what you need to know is that vasoactive drugs will be used to slow down esophageal varices bleeding. You need to be aware that there's other avenues that they can use, but it's not the nurse's call, and this is going to be done off the floor. So just knowing that there are other options is good to know. But you do want to be familiar with the balloon tamponade, because this one is the one that can cause the most side effects, and some of them can be potentially life-threatening complications, like aspiration, esophageal perforation. But don't get bogged down in trying to memorize what all these procedures are. Just know that it is a complication of cirrhosis, and that vasoactive drugs will be ordered, propranolol will be ordered, and there's a host of other procedures that can be done to stop the bleeding. Your responsibility as a nurse is to be able to recognize bleeding. Recognize bleeding through seeing GI bleeding, upper or lower, seeing that the PT count is low, where they're at risk for bleeding, seeing that the H&H is low and maybe they're bleeding, seeing that the platelet count is low and they could possibly bleed or hemorrhage. Everybody follow me? Okay. Another way that we're going to take care of this patient with cirrhosis is managing confusion and preventing confusion in the patient with cirrhosis. What complication is causing the confusion? The hepatic encephalopathy, the elevated ammonia level. So you're going to be assessing that patient's neurological status and monitor them during treatment. And so patients with cirrhosis, they're going to have an increased nutritional need. They're going to need high carbohydrate, moderate fat, and high protein foods. Okay? What medicines will be used to eliminate the body of the ammonia that's built up in the brain? Lactulose. That is a laxative, but it is a way to absorb that ammonia and get it out of the body through the stools. Neomycin is the non-absorbable antibiotic that will be used. The neomycin may be ordered 1 gram every 6 hours. You may see your lactulose given 4 to 5 times a day to help lower. Now, what's happening once they are using lactulose and having the stools, and the stools are removing the ammonia. Is the patient in good shape? What's the complication from having all those loose stools? Dehydration. And what is lost through those stools? Which electrolyte? Which one? Potassium. So you're looking at some dysrhythmias may be occurring. So you'll have to watch and monitor your patient and observe their response to the ammonia-lowering drugs, lactulose or neomycin. Your book did not mention it. Yes, it did. Neomycin sulfate or rifaximin. It is there. Okay. So while you're monitoring that patient's level of consciousness, you're also going to be checking for the icterexis, that flapping hand movement, the fecal hepaticus, that smelly breath. You're going to be monitoring that. And since these patients may have abused alcohol, again, you're going to be looking at supplementing them with thiamine and maybe a benzodiazepine if they're going through withdrawal. Now, how does the nurse manage skin rashes and itching? Remember that bilirubin is elevated, is not being eliminated from the body, so it's up under the skin, making them itch. That's right, and it's there on page 1165 for you. You're going to teach them to avoid being too warm. They need to moisturize their skin, avoid any irritants to the skin. They can put cold compresses or use corticosteroid creams to provide temporary relief. All right. Now, in teaching them about taking care of themselves, what teaching does the nurse send home with this patient? Got to teach them about nutrition. Okay, drug therapy and alcohol abstinence. The what? That's right, because it may be that theirs returns quickly, and they have repeated bouts of that ascites, so they may leave a drain. So they're going to have teaching about how to empty the drain, how to things that they should know to report to the provider about the drain, the color, and the amount, things like that. What type medications will they be on if they've had problems with bleeding and gastric ulcers? Proton pump inhibitors, H2 antagonists. And we're going to stress. What do they need to avoid? NSAIDs, acetaminophen, the Tylenol. Okay. And some herbal type products, before taking over-the-counter vitamins and herbal products, they probably need to check with their provider. So what does the box regarding avoiding Tylenol, what does it emphasize at the very bottom of 1165? Okay. Okay. So what questions do you have about cirrhosis? Be sure that you understand what cirrhosis is, what the patient will report and complain about, some very important things you need to do in assessing the GI system in that abdomen, and the complications that you're going to monitor. and some of these nursing interventions that we've just covered. And be sure that you are aware of what labs you need to monitor while that patient is on your unit. You may be taking care of that patient, and lab will be returning to the unit every day. You need to be sure that you're looking at the lab and responding accordingly. All right, we'll take our first break.